Okay, so we will be discussing how to draw the three diagrams of the transverse section of medulla oblongata at the three levels, uh, which we have covered. This level A, which is at the level of pyramidal decussation, level B, which is at the level of sensory decussation, and level C, which is at the level of the olive or the inferior olivary nucleus. So the first diagram which we see here, how do we go about drawing this? So first of all, we need to draw a cross section, the outline of the cross section. We start from the anterior aspect, where we just draw that shallow anterior median fissure. Then we draw an almost circular, or say slightly oval cross section, and behind, from the midline, we draw two elevations forming the fasciculus gracilis and fasciculus cuneatus. Then in the center, we draw the central canal of medulla. Then we start drawing the dorsal horn, from which the nucleus gracilis and nucleus cuneatus have started growing, and most laterally there is the spinal nucleus of trigeminal which is growing out. And then we continue and draw the ventral horn. Then we go to the other side, we draw the ventral horn again, and we complete the parts of the dorsal horn, showing the forming gracile nucleus, cuneate nucleus, and the spinal nucleus of trigeminal nerve. So the gray matter is done like this. Then the important thing is to draw the, now from here the pyramids were lying and they will start crossing to the other side. So from here the corticospinal tracts will cross to this side like this, to form which tract? Just lateral to the dorsal horn, or just lateral to the spinal nucleus of trigeminal nerve. This tract is the lateral corticospinal tract. Then we will repeat the same thing on the other side. Right? How? It is going like this. Try to draw them straight. These are not coming out exactly straight. This is the lateral corticospinal tract. Now 75% of the fibers, they cross to the other side, whereas 20% remain on the same side and continue down as the anterior corticospinal tract, and 5% also remain uncrossed, but they continue along with the lateral corticospinal tract of the same side. So 75% from here will reach this corticospinal tract, 5% from here will reach this corticospinal tract, and 20% from here will form the anterior corticospinal tract on the same side. Okay, this. Then we draw this midline septum and this intermediate septum between the fasciculus gracilis and cuneatus, and we finish this. Right? So this one is the fasciculus gracilis, this one is fasciculus cuneatus, whereas this one is the beginning of the nucleus gracilis, or the gracile nucleus, which will totally separate from the central gray matter at a level higher than this. That is, when we draw the diagram of section at the level of sensory decussation, we will see that this thing has totally separated, but here it will stay like this. Similar thing will happen to the cuneate nucleus. It will separate from the gray matter. Right? Then finally we have to draw the two ascending tracts which are going from the spinal cord to the cerebellum, those are the spinocerebellar tracts. Those we can simply draw them here and here, right? Here and here. And finally we can draw the spinothalamic tract here, which is carrying the pain and temperature sensation from the opposite half of body here. And in this middle part of the white matter we can draw the reticulospinal tract as well. Okay, so this is the diagram at the level of pyramidal decussation. Pyramidal decussation being this one, where this corticospinal tract is crossing over to this side, this corticospinal tract is crossing over to this side. Okay, then we draw the diagram at the next level, where, okay, one thing I've missed in this one, that is the spinal tract of trigeminal nerve. This thing is the spinal nucleus of trigeminal nerve, whereas this thing is the spinal tract of trigeminal nerve. Spinal nucleus and spinal tract of trigeminal nerve, which the spinal tract is bringing pain and temperature sensations from the ipsilateral half of face, that is from the similar side. If this is the right side and this is the left side, this tract is bringing pain and temperature sensations from right half of face. This tract is bringing pain and temperature sensations from left half of the face, right? Okay, then we move on to the next diagram, which is first let me show you in the PPT. So this is the diagram of the first level, a more detailed diagram in which you see more tracts like spino-olivary tract. In the ascending tracts you see, yes, this is the only additional one, and you also see the anterior spinothalamic tract. Anterior spinothalamic tract lies immediately in the vicinity of the lateral spinothalamic tract. The only difference is that pain and temperature travel in the lateral spinothalamic tract, whereas in anterior spinothalamic tract, what is being the impulses from which modalities of sensation are being carried, that is crude touch and pressure and itching and tickling. Those kind of sensations are being carried in the anterior spinothalamic tract, whereas pain and temperature, they are being carried in the lateral spinothalamic tract. And on the this side you can see the more descending tracts. In addition to the lateral corticospinal, we can see more tracts like the rubrospinal, the vestibulospinal, the olivospinal, and tectospinal, and the medial longitudinal fasciculus. It's okay if you skip them, but we have to draw which ones: the lateral corticospinal, the lateral spinothalamic, and the dorsal and the ventral spinocerebellar. Another additional thing that you can draw is this detached part of the anterior horn. This actually contains the spinal nucleus of the accessory nerve. Sorry. So its spinal root will come out from, again, which sulcus? The posterolateral sulcus, which lies between the inferior cerebellar peduncle and the olive. Even though the olive is not visible at this level, if we go in the next section somewhere here, the inferior olivary nucleus will come into view, which will raise an elevation on the surface called the olive. So between the olive and the inferior cerebellar peduncle is the posterolateral sulcus, or the post-olivary sulcus, from which one of the three nerves to come out is the 11th nerve, or the accessory nerve. Then we come to the diagram of the second at the second level or at the middle level of medulla, which is at the level of the sensory decussations. How to go about drawing this? Okay, I think I forgot to change the. Okay, I did change. You were seeing the PPT. Okay, now I change the scene again back to my drawing board, right? And we draw this second diagram. Okay, right? So in the second diagram, again the outline of the section is more or less rounded. We draw this thing just like we did earlier. Posteriorly from the midline, we will draw the gracile tubercle and the cuneate tubercle. Again, gracile tubercle and cuneate tubercle, which are formed by the underlying nuclei of the same name. We will be drawing them. But first we will draw anteriorly, we will draw the pyramids. Now remember that this pyramid is coming from the same side of cerebrum. If this is the right side and this is the left side, that is, we are looking at the section from above, from the head end, and this is obviously the ventral or the anterior aspect of the section, and this is the dorsal or posterior aspect of the section. This is true for the previous diagram also. So now this corticospinal tract or the corticospinal tract in this right pyramid, the axons have arisen in the right motor area of the right cerebral hemisphere. Okay, but below this level, that is the diagram which we drew before this, these fibers will cross to the other side. That is what had happened in the previous diagram. So eventually that is the reason why the right cerebral hemisphere ends up controlling the left half of the body, and vice versa, that is the left cerebral hemisphere ends up controlling the right half of the body. Okay, so that's there. Then yeah, just undo all this. Okay, I ended up deleting everything. I will draw this thing again. Cuneate, gracile, cuneate, the two pyramids. Now what we will draw separately, the central canal will move slightly backwards. The central canal is going towards the dorsal part of the medulla. Eventually in the highest part of medulla, we would have reached the open part of medulla where the central canal does not exist anymore, but the fourth ventricle has formed. Okay, so in the first section the central canal is somewhere in the middle, but in the second section, this one, the central canal is somewhere closer to the posterior aspect. Then it is surrounded by the central gray matter. We can draw it somewhere like this. And the central gray matter, now a new thing has happened, contains three nuclei. We will discuss these three nuclei slightly later. First of all, we will focus on what is happening at this level. The chief thing that is happening at this level is the sensory decussation. What is happening in the sensory decussation is, first of all, we will draw. Now this was which tubercle? The gracile tubercle. So it will contain deep to it which nucleus? The gracile nucleus. Similarly, the cuneate tubercle, deep to it, will contain the cuneate nucleus, and then lateral to that we can draw the spinal nucleus and the spinal tract of trigeminal nerve, which on the surface raises an elevation which is called as the tuberculum cinereum. Okay, so this is the cuneate tubercle and medial one is the gracile tubercle. Similar things we will draw on the, if this is the right side and this is the left side, on the left side also we will draw. Okay, right. Now in the fasciculus gracilis and in the fasciculus cuneatus, there were first order neurons which were coming from their respective levels of spinal nerves. Their cell bodies were lying in the dorsal root ganglia. Their axons, without crossing over to the opposite side, were ascending. These axons end in the gracile and cuneate nuclei. and here lies the cell body of the second order neuron. Okay, so the axons of these second order neuron, they travel forwards and they cross over to the opposite side. They cross over to the opposite side to form a longitudinally arranged structure immediately behind the pyramid. This structure is called as the medial lemniscus. And the crossing is in such a way that the fibers from the gracile nucleus, which are receiving sensations from lower part of the body, lower limb and the lower trunk, they form the anterior part of the medial lemniscus, whereas the fibers from cuneate nucleus, they form the posterior part. So the upper part of the body is represented here, that is the upper limb and the upper trunk, whereas the lower trunk and the lower limb is represented in the anterior part of the medial lemniscus. The head and neck are not represented here. So the representation of body is that the lower part is represented anteriorly, the upper part is represented comparatively posteriorly in the medial lemniscus. Same thing will happen for the other side as well. First order neurons of fasciculus gracilis end here. These fibers travel forward and they reach here. Ascending first order neurons of fasciculus cuneatus end here. Their axons crossover, reach here, forming the medial lemniscus of the other side as well. Right? This happened. So this decussation, these decussating fibers, these and this whole thing is called as sensory decussation. Okay, and the sensory decussation, the fibers which are decussating here, fibers of the nucleus gracilis, nucleus cuneatus, they are second order neurons and they are carrying which modalities of sensation? They are carrying vibration, they are carrying proprioception, and they are carrying fine touch or 2-point discrimination, the ability to differentiate two closely placed touching points as separate. Okay, this. Then in a similar location we will draw the dorsal and the ventral spinocerebellar tracts, and somewhere in the middle we will draw again the reticular formation. It is nothing but a diffuse collection of axons and cell bodies of neurons which fill up the remaining part of the brainstem. This reticular formation exists in midbrain, pons as well as medulla. And then we will see the beginning of appearance of the inferior olivary nucleus, which looks somewhat like a crumpled bag, but it is not yet completely visible here. It will become properly visible at the higher level, but we will nevertheless just draw it. Right, and then we can draw the lateral spinothalamic tract in a similar location here. Remember that the lateral spinothalamic tract carries which modalities of sensation? Pain and temperature, and these have already crossed in spinal cord at the level where the axons entered. Suppose if from the upper limb the axons carrying pain and temperature enter at C5 to T1 level, they will cross at their respective spinal segment level only. Right, and it is the second order neuron only where this all will be covered in detail when the spinothalamic tract is covered in detail. Right, so this is the diagram of the second level. In this, now if we have a look again at at our PPT. Right, now in a slightly where is this? Yes, here you can add a couple of more tracts, again the same: rubrospinal, vestibulospinal, olivospinal, and these are the descending tracts that you can add. And on the ascending side you can add which one? The anterior or the ventral spinothalamic and the spino-olivary. But the main ones which are required I've already told you. Yes, and I forgot to discuss about the three nuclei uh, present in the central gray matter. What are these nuclei? If we give them the number 1, number 2 and number 3, number 1 is the nucleus of the 12th cranial nerve, the hypoglossal nucleus. Number 2 is the dorsal nucleus of vagus, that is the 10th cranial nerve. And then number 3 is the nucleus of the solitary tract, or it is also called as nucleus tractus solitarius. We will see at the higher level, that is at the level of transverse section, at the level of olive, that when the central canal opens up in the form like this area will form the floor of fourth ventricle. So these nuclei will come to lie immediately below the floor of the fourth ventricle. Okay, so now let us draw the third diagram, which is at the level of inferior olive. Okay, now the outlining of this diagram is slightly different. The anterior central part is the same. You have to draw the pyramids. Okay, and then you start the posterior midline point. You draw these 1, 2, 3 elevations like this. 1, 2, 3 elevations. Okay, now between this point and this point we have to draw two large elevations. One of them is facing posteriorly and laterally, the other one is facing somewhat anteriorly and laterally. Similarly on this side, this one faces posteriorly and laterally. Okay, kind of like this, and the anterior one faces anteriorly and laterally. This one is supposed to be the olive, and this one is supposed to be the inferior cerebellar peduncle, which connects each half of medulla to the cerebellum. And these are obviously just the same which we have drawn in the other two sections also, the pyramids. So this will be with sulcus, the pre-olivary or the anterolateral sulcus, and this will be the post-olivary or the posterolateral sulcus. This is the pre-olivary or the anterolateral sulcus. Right. Okay, then we start drawing. सबसे पहले first of all we will draw the pyramids. Then immediately behind the pyramid, close to the median plane, we will draw the medial lemniscus. Again, the crossing of the medial lemnisci has happened at a level lower than this, that is at the level of sensory decussation, so that each of these medial lemnisci is carrying the sensations of vibration and proprioception from the other half of the body. Then remember those three nuclei of central gray matter, that is the hypoglossal nucleus, that is present most medially, forming this elevation. This will form something called as the hypoglossal triangle. This we will see in the floor of fourth ventricle. It is a separate lecture. Then lateral to it we have the two nuclei of vagus. This is the dorsal nucleus of vagus, and ventrolateral to it is the nucleus of the solitary tract. Here this elevation is formed by another nuclei of the 8th nerve, the vestibulocochlear nerve. These are the vestibular nuclei. Okay, so same thing we will repeat on the other side. This is the hypoglossal nucleus, then this is the dorsal nucleus of vagus, and ventrolateral to it is the nucleus of the solitary tract, and then we have the vestibular nuclei. This whole structure is simply the inferior cerebellar peduncle, and just deep to it now the inferior cerebellar peduncle is covering the spinal nucleus and tract of trigeminal nerve. So you have to draw deep to the inferior cerebellar peduncle. Okay, then there is another nucleus of vagus nerve. Remember, this was the dorsal nucleus of vagus nerve. This was called as this one is called as NTS. Then there is another nucleus called as nucleus ambiguous. This also belongs to the 9th, 10th and 11th cranial nerves. Okay, I will tell you what is the significance of these three nuclei, NTS, dorsal nucleus and nucleus ambiguous. But first of all, we will draw the structure forming the olive. So the structure forming the olive, as we have discussed in the earlier diagram also, is the inferior olivary nucleus. So we will draw it with a crumpled bag appearance. Okay, and similarly on this side, draw it with a crumpled bag appearance. But there are two more olivary nuclei. One is on the medial aspect between the medial lemniscus and inferior olivary, that is called as the medial accessory olivary nucleus, and then we have a dorsal accessory olivary nucleus as well, dorsal to the main inferior olivary nucleus, right? And another important tract that we have is the lateral spinothalamic tract, right? Now, what happened to the dorsal and ventral spinocerebellar tracts? The dorsal spinocerebellar tracts forms a part of the inferior cerebellar peduncle, whereas the ventral spinocerebellar tract is still separate. So ventral spinocerebellar tract is here, but the dorsal spinocerebellar tract has formed a part of the inferior cerebellar peduncle. Okay, so this is inferior cerebellar peduncle, out of which the dorsal spinocerebellar tract is now entering the inferior cerebellar peduncle, right? Now what is remaining in this thing? There is another, we can slightly prolong this medial lemnisci slightly like this. Now between the medial lemnisci and the hypoglossal nucleus there are two more pairs of tracts or bands. This one is called as the medial longitudinal fasciculus and this one is called as the tectospinal tract, and these are related with the movements of eyes with relation to the location of the head. This medial longitudinal fasciculus connects the nuclei of which cranial nerves 3rd, 4th, 6th, 8th and 11th. Because this is associated with head movements, this is associated with detecting the location of head in space via the vestibular nuclei, via the inner ear, semicircular canals, and these three are involved in controlling the movements of the eyeball by controlling the extraocular muscle. So all nuclei of all these cranial nerves are connected by the medial longitudinal bundle or the this medial longitudinal fasciculus, which is present here. Immediately in front of it is the tectospinal tract, and in front of that there is the medial lemniscus. This is the medial lemniscus, which was formed by the sensory decussation. Okay, so which cranial nerves we can draw coming out of the medulla at this level? Number one is vagus. Now remember the 9th, 10th and 11th nerves emerge out of which sulcus? This sulcus, the posterolateral sulcus, which is present behind the olive. So here we can show the vagus nerve. Vagus nerve is carrying fibers from the NTS, from the dorsal nucleus and the nucleus ambiguous. So this is the vagus nerve. Whereas here we can show the hypoglossal nerve. Its fibers travel forwards and slightly laterally and emerge out of this sulcus. This sulcus is the pre-olivary sulcus between the pyramid and the olive. So anterolateral pre-olivary sulcus. From here the hypoglossal nerve comes out. So similarly thing we can draw on this side. This will come out here. So that is why hypoglossal nerve comes out through closer to the midline, that is through the anterolateral sulcus, whereas the vagus nerve, which is receiving fibers from, I have not drawn the nucleus ambiguous here, so the vagus will come out here receiving fibers from NTS, from dorsal nucleus, and from nucleus ambiguous. This is our vagus nerve. Okay, and this whole thing, this whole space behind the medulla, now this is the open part of medulla, so this whole space is the fourth ventricle. This surface of medulla is actually forming the floor of the fourth ventricle, whereas behind this the cerebellum will form the roof of the fourth ventricle. So here the lateral walls of the boundary of or the floor of fourth ventricle is formed by the inferior cerebellar peduncle. The central part of the floor is formed by vestibular nuclei, the nuclei of vagus and the nucleus of hypoglossal nerve. Okay, in this same diagram we can discuss what, let me just clean some space around it. We can discuss the lateral and the medial medullary syndromes. Okay. Right. Okay. Now, if I let me use this color and slightly thicker. Now, this medial area, this whole area medial to the olive, this is supplied by which arteries? Somewhere here is lying the anterior spinal artery, actually not here, slightly below in front of spinal cord, but there will be formation of the anterior spinal arteries. Let me show you how by changing to our PPT again. Let us go to the blood supply of spinal cord. Yes, right. So I don't know if I can draw here or not. Yes, where is the pointer? Okay, I guess I cannot draw here. I don't know if you are seeing the pointer or not, but you see in the middle of the brain, this is the brain stem. In front of medulla, there are two thick arteries lying the vertebral arteries. From medial aspect of each vertebral artery, a thin artery is arising, that is called as the anterior spinal artery. Both of them unite to form a single anterior spinal artery, which lies in the anterior median fissure of medulla and below anterior median fissure of spinal cord also. So the midline part of medulla is supplied by the anterior spinal artery or by direct branches from the vertebral arteries of either side, whereas the lateral part, that is supplied by the pica. These two, let me show you. Vertebral arteries are these two. Then, which are the anterior and posterior spinal artery? This is showing only the anterior spinal artery. Posterior spinal artery is not shown. That will arise on the posterior aspect. Then, the inferior cerebellar arteries. There are two pairs of arteries on the inferior surface of cerebellum. These ones which arise from the basilar artery in the midline. How is the basilar artery found? By the union of the two vertebral arteries. So from the proximal part of basilar artery, an artery arises which supplies the anterior part of inferior surface of cerebellum. So it is called as anterior inferior cerebellar artery or AICA. That is a branch of basilar. Whereas in purple, these two arteries which arise from the vertebral arteries, they supply the posterior part of inferior surface of cerebellum. So they are called as pica or posterior inferior cerebellar arteries. So it is the pica arteries chiefly which supplies the dorsolateral part of the medulla. Okay, so this part of medulla you see is supplied by the pica. Right, so now we will study the medial medullary syndrome and the lateral medullary syndrome. What happens in the Medial medullary syndrome. First of all, I will again change the scene to my drawing board. Yes, now in this pink colored area, this is the area supplied by the anterior spinal artery and or direct branches from the vertebral arteries. Okay, so this area will lose its blood supply. So what will happen? Which part is getting affected? Number one, the pyramid is getting affected. What will happen because of affectation of only, suppose this is the right side, this is the left side of the patient. By involvement of the right pyramid, this right pyramid is containing motor neurons coming from the right cerebral hemisphere. But what is going to happen to these neurons? They are going to cross over to the other side at the level of pyramidal decussation, the lowest level of medulla, and they will form the lateral corticospinal tract somewhere here, but on the left side, which will descend in the left side of spinal cord, and that will supply the motor neurons in the ventral gray horn of left side of spinal cord, which will travel in the spinal nerves of left side, supplying the left side of body. So this pyramid is involved in supplying the other side of the body, and this pyramid is involved in supplying the other side of body. So that is why by involvement of pyramid there will be motor loss, or that is paralysis, but on the other half of the body, that is called as contralateral hemiplegia. Contralateral means on the side opposite from the side of lesion. If the lesion is on the right side of brainstem, then the side of body affected will be left. If the lesion is on left side of brainstem, then the side of body affected will be right. So contralateral means the opposite side. So there will be contralateral hemiplegia. Hemiplegia means paralysis of both the upper limb and the lower limb. So if the right pyramid is affected above the level of pyramidal decussation, then both the left upper limb and the left lower limb, they will be paralyzed. This is called as contralateral hemiplegia. Okay, then second thing which will be affected is this, the medial lemniscus. Now if you remember, medial lemniscus is formed by decussation of the fibers from nucleus gracilis and nucleus cuneatus. Now imagine, this is the right medial lemniscus. This was formed by fibers coming from this side, which were bringing sensations from which half of the body? Left half of the body. So again we are above the level of decussation. So if above the level of decussation any fiber is affected, then contralateral part of body will be affected. However, if the lesion had happened at the level of spinal cord, if the fasciculus gracilis or cuneatus were affected, then the ipsilateral half of body will be affected, because then we are below the level of decussation. Right. So because of involvement of this right medial lemniscus, now we are assuming that the right median part of the medulla is affected. So the right medial lemniscus has been affected, so that will cause loss of sensations carried by the dorsal tract, that is vibration, then proprioception, and 2-point discrimination from the contralateral half of the body. Body here means the trunk and the limbs. Okay. So because of pyramidal tract, again I am repeating, there is contralateral hemiplegia. Because of medial lemniscus involvement, there is contralateral loss. There is loss of vibration, proprioception, and 2-point discrimination from contralateral half of the body. And finally, because of involvement of hypoglossal nucleus, the same side of the tongue will be paralyzed, because here this hypoglossal nerve, this right hypoglossal nucleus gives rise to the right hypoglossal nerve, which supplies the right half of the patient's tongue. So if this is the patient's open mouth and this is the patient's tongue, if you are looking at the patient's right side and left side, then the patient's right half of the tongue will be paralyzed, But if we ask the patient to protrude their tongue will deviate to the normal, not the normal side, but to the paralyzed side only. Why? Because there is a muscle called genioglossus which is responsible for this deviation. The genioglossus of the normal side is intact, but genioglossus of the affected side is paralyzed. So this genioglossus of the normal side causes pushing of the tongue, deviation of the tongue to the opposite side, which is the side of the lesion. That is why we say there is, because of involvement of hypoglossal nucleus, there is paralysis of ipsilateral half of the tongue, and there is deviation of tongue to the ipsilateral side on protrusion. So these three are the features of medial medullary syndrome, which is also called as the medial medullary syndrome of Wallenberg. Medial medullary syndrome of Wallenberg. So contralateral hemiplegia because involvement of pyramid, loss of vibration, proprioception, 2-point discrimination from contralateral half of body because of involvement of medial lemniscus, and then there is paralysis of ipsilateral half of tongue and deviation of the tongue to ipsilateral side on protrusion because of involvement of hypoglossal nucleus. Then let me again clean up all this. What will happen if the dorsolateral part of medulla is involved? What will happen then? Okay. Now the dorsolateral part of medulla will involve what? This area. Let me change to the pencil. Yes. All this area lateral to the olive, that will cause the syndrome called as the lateral medullary I think I mixed up. The medial medullary syndrome is not Wallenberg. हाँ वो तो lateral है. The medial medullary syndrome is of Dejerine. Yes, I mixed up. Please correct that. The medial medullary syndrome is also called as the Dejerine syndrome, medial medullary syndrome, or Dejerine anterior bulbar palsy. Wallenberg is the lateral medullary syndrome. My mistake. Lateral medullary syndrome of Wallenberg, which is also called as the posterior inferior cerebellar artery syndrome. Why? Because the dorsolateral part of medulla is chiefly supplied by the posterior inferior cerebellar artery. Now the features of lateral medullary syndrome will be what? Now most importantly, which structure? Let me use a different color to mark the structures which are affected. Number 1, the lateral spinothalamic tract. This is carrying pain and temperature from contralateral half of body. So there will be loss of pain and temperature from the contralateral half of body. Body here means trunk and limbs. Why do we need to differentiate? Because the second part affected is the spinal nucleus and tract of trigeminal nerve. This is also carrying pain and temperature, but from ipsilateral part of face. So, in lateral medullary syndrome, because of involvement of spinothalamic tract, there will be loss of pain and temperature sensations from the contralateral half of body, that is the trunk and the limbs. But because of involvement of the spinal nucleus and tract of trigeminal nerve, there will be loss of pain and temperature sensations from ipsilateral half of face. Example, in this case, if this is right half of the body, this is left half, because of involvement of right spinothalamic tract, right lateral spinothalamic tract, there will be, the patient will be unable to feel pain and temperature sensations on his left side of the trunk, that is thorax, abdomen, on the left half of the thorax and abdomen, on the left upper limb, on the left lower limb, patient will not be able to feel any sensation of pain and temperature. But because of involvement of right spinal nucleus and spinal tract of trigeminal nerve, the patient will be unable to feel pain and temperature sensations on his right half of face only. So left half of trunk and the left upper and lower limbs, but right half of the face when the lateral medullary syndrome is affecting right half of the body. Basically, by spinothalamic tract, contralateral half of body will face the loss of pain and temperature sensation, but ipsilateral half of body will face the loss of pain and temperature sensation. Not ipsilateral half of body, ipsilateral half of face. Okay, which other structure is affected? Number 3 is the inferior cerebellar peduncle. Now inferior cerebellar peduncle is the afferent peduncle. Most of the sensory fibers entering the cerebellum, they enter through the inferior cerebellar peduncle. So all the input to cerebellum is gone. That will lead to ataxia, difficulty in walking and equilibrium, staying straight. Then ataxia will be ipsilateral, because each half of cerebellum is responsible for control of ipsilateral half of the body. So the ataxia will be on the ipsilateral side. And finally, which other structure? The nucleus ambiguous, because this is also being affected. This leads to paralysis of muscles supplied by the 9th, 10th and 11th nerve, which include the muscles of soft palate, then pharynx and then larynx. Because of involvement of soft palate muscles, there will be dysarthria, difficulty in articulation of words, which will happen by paralysis of lips also, paralysis of tongue also, but it can happen by paralysis of soft palate also. Because of paralysis of muscles of pharynx, there will be difficulty in swallowing, that is dysphagia. And because of paralysis of muscles of larynx, there will be difficulty in producing voice, that is dysphonia. So these features will be happening because of nucleus ambiguous. There is another feature, number 5, I will write it here. Because of involvement of these are the vestibular nuclei. Because of involvement of these, there will be, the patient will experience nystagmus. Actually, not the patient will experience, the physician will be able to see that his eyes are moving involuntarily to and fro movement, that is called as the nystagmus. And then there will be vertigo, giddiness, and the patient might experience vomiting as well. So that is because of involvement of the vestibular nuclei. There is vomiting, nystagmus, vertigo, giddiness. That happens because of involvement of. So all these 5 are the components of the lateral medullary syndrome of Wallenberg, or the posterior inferior cerebellar artery syndrome. Right. So I think that's all.